shoulder AP, which is the AP external rotation. So our patient is in standing horizontal to our IR. So the humeral epicondyle must be placed at the parallel to the IR plane, scapula humeral joint at center of the image receptor. Body is slightly rotated to our affected side. Head is insupinated. So the head of our patient must be far away to our radiographic image receptor. So the central ray in this projection is that. So the central ray in this projection is the perpendicularly directed 1 inch distal to coracoid process. So the projection shows in this projection is that demonstrate the true AP of the shoulder, greater tubercle of the proximal humerus, and the site of insertion of the super. Is the AP neutral rotation. So same the position in upper and appear. So, but hand is placed at the side in contact to our IR. With the hip, ito po yung hip po ng patient natin. So, dapat po dikit lang po yung position po ng sa patient natin. Nakaganyan po siya. So, the central ray in this projection, is the perpendicularly directed 1 inch distal to coracoid process. So, the structure shown in this projection is the posterior part of the superaspinatus insertion. Both greater and lesser tubercles often superimposed by humeral head proximal to our humerus. So, the image receptor is 10/12 image receptor, and we had the secondary marker, and we had the meter stick. So, we're going to do is the AP internal rotation. So, the patient is in same position. So, in upper, but hand is internal. So, rotation until the back of the hand is resting on to our hip. So, the central ray in this projection, is perpendicularly directed 1 inch distal to coracoid process. So, the structure shown in this projection shows true lateral of proximal humerus and greater tubercle superimposed over humeral head. The projection that we're going to do is the AP internal rotation. We're going to use the meter stick, and we're going to use the image receptor, which is 10/12, and secondary marker. So, instruct the patient to position in upper to our image receptor. Yan. So, but the hand is internal rotation until the back of the hand resting on the hip. So, the central ray in this projection, is that perpendicularly directed 1 inch distal to coracoid process. So, the structure shown in this projection is the true lateral of proximal humerus and greater tubercle superimposed over humeral head. So, the second projection that we're going to do is the transthoracic lateral projection, Lorentz method, right or left position. So, the patient is standing, elevated, unaffected arm. Side po kay ate. So, yung patient po natin is dapat po naka-side po siya, tapos yung hand niya po is naka-taas po siya. So, the arm is to prevent superimposition of the shoulders. So, the patient is standing position. So, the central ray in this projection is that our central ray in this projection is perpendicularly directed to the thorax to mid-diaphysis. So, the structure shown in this projection is lateral image of the shoulder relationship of humeral head and glenoid cavity, and proximal humerus through the thorax. Second projection that we're going to do is the infero-superior axial projection, Crawford modification. So, the patient is dapat po, nakahiga po yung patient natin. Imagine na lang po na ito po yung sandbag na gamit-gamit po natin sa radiographic. So, the image receptor po natin is 8 by 12 and our secondary marker. And we had the meter stick. So, we're going to put the image receptor so yung same position in Lawrence method. So, but extended arm is externally rotated until the hand forms as 45 degrees of oblique thumb pointed downward. So, our central ray in this projection is direct central medially 15 degrees, centered horizontally to axilla and humeral head. So, the structure shown in this projection is heel sacs, compression fracture, proximal humerus, and scapulohumeral joints. So, the third is the infero-superior axial projection, West Point method. So, shoulder joint. So, our patient is in prone shoulder and arms are elevated with the use of sandbag. Head is turned away from affected side. Abduct is 90 degrees. So, the forearm is hanging at the side of front table. So, the central ray in this projection is 25 degrees medially and anteriorly entering shoulder joint, 5 inch inferior and 1.5 inch medial to acromial edge. So, the structure shown in this projection is that the bony abnormalities of the inferior rim of glenoid. The fourth in this projection is the infero-superior axial projection, Clement's modification. So, we're going to position the patient in lying towards the unaffected side. Flex hips. So, flex po natin yung hips natin, nakaganyan. So, the hand must be flexed at the ceiling. So, the place is, the IR is against the superior aspect of the shoulder and unaffected arm. So, we're going to hold the image receptor, which is 8 by 12. So, the central ray in this projection is horizontal to the mid-coronal plane, passing through the mid-axillary region of the shoulder. So, the structure shown in this projection is the space of the shoulder joint. Okay. Glenoid cavity, apple, Grash's Gart method, and we're going to use the image receptor, which is 10 by 12, our secondary marker, and we're going to use the meter stick. So, the glenoid cavity is AP oblique projection, RPO or LPO position, apple method. So, instruct the patient to upright hand of the affected shoulder. So, 90 degrees and 1 pound weight placed 45 degree. Body root is center is scapulohumeral joint. Center of the IR is scapula parallel to the IR. So, the central ray in this projection, is to coracoid process. So, the structure shown in this projection is the loss of articular cartilage, scapulohumeral joint. That we're going to do is glenoid cavity, apple Grashe Gart method. We're going to use the 10 by 12 image receptor and the glenoid cavity, AP oblique projection, RPO or LPO position, apple method. So, the patient is in upright, hand of the unaffected area of shoulder, abduct 90 degrees, 1 pound, and weight place 45 degree. So, the body root is center scapulohumeral joint. At center of image receptor, scapula is parallel to our IR. So, the central ray in this projection is the coracoid process, loss of articular cartilage, scapulohumeral joint. The second projection is the AP-oblique projection, Grashe method, glenoid cavity. So, the patient is body rotated in 35 to 45 degrees towards to our affected area. So, the center is mid-scapulohumeral joint to IR, slightly abduct, arm flex, neutral rotation. So, the central in this projection, the central ray in this projection is perpendicularly directed to scapulohumeral joint, 2 inches inferior and medial from superlateral border of shoulder. So, the structure shown in this projection is the glenoid cavity without the superimposition of humeral head. Scapulohumeral joint is the apiaxial oblique projection, Gart method, RPO or LPO position. So, the patient is in upright 45 degrees, body root, elbows is flexed. So, the hand placed across the chest region in pronation. Para po siyang ganito po yung position. So, tama po yung position ng pasyente natin. So, the central ray in this projection is 45 caudal to scapulohumeral joint. So, the structure shown in this projection is heel sac lesion, scapulohumeral joint, coracoid process. The fifth projection that we're going to do is the clavicle apiaxial lordotic method. So, the first one that we're going to do is the AP clavicle. So, we're going to use is the image receptor is 10/12. So, we're going to use the secondary marker and meter stick. So, instruct the patient supine or upright in AP projection. So, yung hand po ng patient po natin is dapat po siya nakastand ng ganito. Place the arms along the sides of the body, posterior part of body in contact with IR. So, to the mid-clavicle, so our central ray in clavicle is the mid-clavicle. So, the structure shown in this projection is frontal image of clavicle. What we're going to do is the apiaxial projection, lordotic position. So, instruct the patient to stand and the patient lean backwards in our extreme lordosis position. So, until the upper posterior thorax in contact to the IR and arms is in contact to the VCH at the side of support, rest head and neck in the VCH center IR to the mid-clavicle crosswise. So, instruct the patient to suspend respiration at the end of full inspiration to elevate and angle the clavicle. So, the central ray in this projection, our central ray in this projection is set up to 15 degrees to mid-clavicle if patient is in standing position, and 5 to 30 degrees if in supine position. So, the structure shown in this projection is axial image of the clavicle projected above the ribs. The 10th projection that we're going to do is the apiaxial pelvic inlet, which we're going to use the 14-17 image receptor. So, the patient is in supine position. So, our patient is in supine position. The lower limbs internally rotated 15 to 25 degrees from the hip. So, our image receptor is nakaganyan po siya sa ating pasyente. So, the IR is the center of the IR to the mid-sagittal plane to the level of the iliac crest. So, the central ray in this projection is that our central ray in this projection is 25 to 40 degree caudal entering to the mid-sagittal plane to the level of the iliac crest, perpendicular to plane of pelvic inlet. So, the structure drawn in this projection is the entire bony pelvic ring without the superimposition. So, the 11th projection that we're going to do is the hip AP projection. So, the patient is in supine position. So, patient is, pelvis is adjusted so that there is no rotation. Foot is rotated internally 15 to 20 degrees to place the femoral next parallel to our IR. So, we need to put our image receptor which is 14 to 17 inches. Sige po. So, yung paa po ng patient natin is naka-rotate po siya internally. Ganyan po siya, 15 to 20 degrees. So, our central ray in this projection, is the femoral neck entering approximately 2.5 inches distal on a perpendicular line down to the midpoint of a line between the axis and pelvis pubic symphysis. So, the projection that shown in this projection is the hip and the neck trochanter. Projection that we're going to do is the lateral Lowenstein and Hicking method, which we're going to use the 14 by 17 crosswise image receptor, and we're going to use our secondary marker, and we're going to use our meter stick. So, we're going to do first the Lowenstein position. So, our patient is in supine position, rotated slightly to the affected area. So, the side until the leg is abducted to oblique positioning. Place the sandbag at the hip of the support or unaffected limb and elevated, and put sandbag under the flexed knee. Knee in the body is femur parallel to the table. So, we're going to put our image receptor then we're going to do is that in Lowenstein projection to the hip is located bent axis and pubic symphysis. So, the projection in this projection, the central ray in this is 20 to 25 cephalad. So, the structure shown in this projection is lateral of the hip, acetabulum, and proximal femur. So, 13 projection is the upper anterior ribs. So, we're going to do is the PA projection. So, patient is placed the upright position facing to the IR. Wait lang. So, the IR is 1 to 5 inches above the relaxed shoulder to include the upper ribs. Center the mid-sagittal plane of the patient body to the midline of the IR. So, the neck is hyperextended. Flex the elbow and place the position of the hips. So, posterior part of the hand is resting on the hip. Rotate the scapula away from the rib cage. So as you can see, our central ray in this projection is perpendicular to the IR, entering to the T7 midway between the inferior border of the scapula. So, we're going to instruct the patient to suspend at full inspiration to depress the diaphragm as much as possible. So, the structure shown in this projection is the rib cage and scapula. Projection is lower anterior ribs. So we're going to do the PA projection. So instruct the patient the mid-sagittal plane of the patient body to the midline of the IR. So neck is hyperextended and chin resting on the VCH, hands is against the hip. So our central ray in this projection is that perpendicular to the IR, entering the T7. So, suspend at the full expiration to elevate the diaphragm. So, the structure shown in this projection is lower anterior ribs below diaphragm are demonstrated. Is the sternum PA oblique projection, Moore method, modified prone position. So our patient, we're going to instruct the patient to place the patient at the side of the radiographic table, ask the patient to bend at the waist and place the sternum. So, the sternum at the center of the IR, place the patient arms above the shoulder and palm down on the table. Ensure that the patient is in true prone position. Head is turned away from the tube. So, the patient, we must instruct the patient to take slow and shallow breathing during the exposure. So, the central ray in this projection is 25 degrees towards approximately 2 inches to the right spine, entering at the level of T7. So, the structure shown in this projection is sternum free from superimposition of vertebral column. What we're going to do is the SC joint PA oblique projection. We're going to use the 8x10 lengthwise. So, we're going to do that the patient is placed in the prone position facing the image receptor. Wait lang ate. So we're going to put our image receptor and the hand of our patient is at the back. So, hand is placed side at the body and palm facing upward. Adjust the shoulders to lie in the same transverse place. Central ray requires a 15-degree central ray angulation. So the level is T2. So you can see T2 and T3 inches distal to vertebral prominence and 1 to 2 inches lateral to mid-sagittal plane. Head is facing away from tube. Place affected SC joint center of the IR. So, our central ray in this projection is the 15 degrees tube angulation towards the mid-sagittal plane. Enter at the level of T2 and T3. 3-inch distal to the vertebral prominence and 1 to 2 inch lateral to the mid-sagittal plane. So, the structure shown in this projection is slightly oblique of the sternoclavicular joint is demonstrated. So, 17 projection that we're going to do is SC joint PA oblique projection, body rotation method, RAO or LAO. So, we're going to use the 10x12 image receptor. The patient is in prone position. Kagaya po sa kanina sa 16 na position po natin, nakadapa po ang ating pasyente. So, yung kamay po ng pasyente natin ay nasa likod. So, the left is affected, we will use the LAO position and vice versa. And since the affected side of the patient, we will use the raw position. Place the patient in oblique angle at least 15 to 20 degrees. Center the SC joint, the midline of bridge shoulder lie, and the same transverse plane. So, our central ray in this projection is perpendicular to the sternoclavicular joint closest to the IR. Enter at the level of T3 inch. Distal to the vertebral prominence and 1 to 2 inch. Toward the joint from the mid-sagittal plane. So, instruct the patient. The patient is to suspend at the end of the expiration to obtain a more uniform density than exposed. So, the structure shown in this projection, as you can see, oblique image of sternoclavicular joint is demonstrated. 18 projection that we're going to do is the AP projection bilateral Pearson method AC joint. So, the image receptor that we're going to use is that 8x10 image receptor bilateral projection of our AC joint. So, the patient is in upright. Adjust the center of the IR at the level of AC joint patient's arm. Hanging at the side, place the shoulder to the same horizontal plane. Both shoulder is taken for comparison. So, two exposures weight is 5 to 8 lbs. The weight on the wrist with the use of elastic band without weight. So, the central ray in this projection, so, two acromioclavicular joint. So, the structure shown in this projection is bilat image of the bilat image of the acromioclavicular joint for dislocation, separation, relationship of the clavicle and the acromion process. 19 is chest AP and PA projection. So we're going to use the 8x10 image receptor. So the patient is facing to the IR, standing the position. So yung kamay po ng patient po natin ay nakalagay po sa hip po ulit. So at the lowest of position, air fluid seen is patient is in chin upward. Flex the elbow, then press the rotate shoulder forward to the position, then elbow. So, the body to the midline of IR, upper border of the IR, place 1.5 to 2 inches above the shoulder. So, instruct the patient suspended respiration at the end of the second full inspiration. So, the central ray in this projection is perpendicularly to the IR entering the level of T7. So, the structure shown in this projection is air-filled trachea, expanded lungs, diaphragmatic domes, and heart, and aortic valve. The projection that we're going to do is the chest AP. So, the patient is facing the tube and posterior part of the body is in contact to our IR. So, the hand of our patient is like this. So, standing position recommended to place diaphragm. Its lowest position is air fluid is seen. Center the MSP of the body to midline of IR, upper border of IR, place 1.5 to 2 inches above. The shoulder, if if possible, flex the elbow and palm of the head is in hips. Adjust the shoulder to lie in the same transverse plane. So, instruct the patient, suspend respiration at the end of the second full inspiration for the full expansion of the lungs. So, our central ray in this projection is perpendicular to the long axis of sternum and center of IR, entering 3 inches below the jugular notch. So, the structure shown in this projection is air-filled trachea, expanded lungs, diaphragmatic domes, heart, the aortic knob. Since the anatomy is closer to the tube, the heart and greater vessels is magnified. For the last part, projection is the chest, lung, apicus, lordotic view. So, the projection that we're going to do is the AP axial projection, Lindblom method, lordotic position. So, the patient is in upright position. The patient is facing the X-ray tube. Upper border placed 2 inches above the shoulder. Instruct the patient to learn until posterior thorax in contact to IR, head resting on the VCH to place PX, lordotic position, MSP of the body centered to the midline of the IR. So, suspend respiration at the second full inspiration for the full expansion of the lungs. So, the central ray is perpendicular to IR, entering at the level of mid-sternum. So, the structure shown in this projection is AP axial images of the lungs, apicus, and conditions such as interlobal effusions. So, thank you everyone for watching.